Approaching the CW extension, or are you actually in the Northgate Village Apartments now?
Well, I can tell you it's been a very, very dangerous and extremely fast pursuit. They've been chasing that van right there. Now,
That's exactly what he's doing. Hi, are you Googling the laws right now?
Henderson Police Department's SWAT team responded to the scene and set up a perimeter around the condominium.
I travel in and out of time zones.
And the 3 key rules for a criminal defense lawyer: always on time, impeccably dressed, and occasionally sober.
The yellow sports car up ahead won't stop. Then, something happens you might expect in a Spider-Man movie. It wraps around the tire of the fleeing vehicle and stops all forward motion.
Objection, action answered.
I mean, he leaps over the fucking bench.
No, the thing is that's my property. You have no choice.
Actually, I do, because I found friggin' Xanax bars on your driver's seat. If you want to explain something, explain those.
Cops get very frustrated when you don't answer their questions.
No.
Right, put the knife on
He's gonna go straight. There's a car right here. Got him.
All right, I'm going to excuse everyone. Mr. Brooks is being removed from the courtroom.
This is fucking hilarious. So he pulls out a joint in court.
Go, 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 go.
Turn on your stomach! Stop fighting us! Stop resisting!
The injury by the police, that may be a separate issue for you to file a civil suit.
Chris, just while he's doing that, talk to me. What were you running for again?
Warrant.
Warrants? A felony warrant, city warrants, what?
Felony warrant on Kansas.
Well, I'm pretty sure they ran you, and you don't have any warrants.
I don't.
No.
No warrants.
No. So all that for nothing, right? No warrants, no nothing.
Yeah.
Police! A little farther back. A little more. Okay, go.
I'm not finna sit here and let you fix the trial because you don't want to tell the truth to the jury.
We're there, guys. Got eyes on.
I want to suck it. Yes, I think I would like to suck your dick. I don't think so.
I prefer not to.
I prefer not to, sir. See, that I love that.
So do you wish to say anything?
No, ma'am.
All right, thank you.
Hello again. Welcome to the Defence Rests. I'm Jody, and thank you for joining us again. Hopefully you caught last night's live stream where I went through a detailed theory on exactly what I believe went down on February the 29th in Canton, Massachusetts, to John O'Keefe. So if you haven't yet seen that, I recommend you go back and have a look at yesterday's live stream. It was a deep dive into the timeline and my theories on what I think went down based around all the evidence and the facts of the case and the dog and the phone records and testimonies and, as I said, the timeline. So today I thought I might go through Dr. Rice's testimony from Tuesday. He was the ER physician that treated John O'Keefe when he presented at the Good Samaritan Hospital. And he arrived there, I believe it was around the 6:47 mark. And then he was there and he was pronounced deceased at 7:50 a.m. So in his testimony, he was asked quite a few questions from Lali, and his explanation as to the resuscitation techniques and processes and guidelines and protocols that are normally in place for that kind of emergency resuscitation weren't very well explained. So I thought I might go through in a little bit more detail, just so that you understand what the processes are, why they do what they do, how they do what they do, and a little bit of anatomy and physiology, just to explain it a little bit more and understand how everything fits, basically. I have had 12 years of nursing experience and worked in intensive care and coronary care as well. So, but I have based the latest advanced life support care. I haven't worked in the industry for over 10 years, so I researched the current guidelines for advanced cardiac life support. So I've prepared a little bit of a presentation on that. But what I thought we'd start off with the testimony of Dr. Rice, Dr. Justin Rice. He's an ER physician that treated John O'Keefe, and I would address the issues as we go. So let's get into it, shall we? All right, so this is day 18, the afternoon session of the Karen Reid trial. The morning session was where the John O'Keefe's niece and nephew were actually called to testify on the stand, which I completely disagree with. But yeah, they've gone through enough. They didn't need that testimony, as far as I'm concerned. But it was just cruel. It wasn't televised, and it wasn't recorded in audio either. So, but the reporters that were in the courtroom were able to take pen and paper notes and have since obviously let us know what was said, which was pretty much fruitless. It explained a pretty much normal, everyday relationship.
You want me to look through each page or just acknowledge that?
Just as far as, do you recognize what that document is?
Yes, of course.
And what do you recognize that to be?
So it looks like is a transcription or a copy of the medical chart that I would have produced or dictated. And on the front page is also a, it's called like a code sheet, which the nurses would have put together and I would have signed off on, detailing what resuscitative efforts, as in the specific details.
All right, so right there, he is the physician in charge of John's resuscitation, but every person within that resus bay is responsible for their own part they play. So each one is allocated their own responsibilities. One person or two people will be doing, will be allocated to maintaining an airway and the breathing. Another person will be doing IV access and central lines or whatever. The other person will be doing the heart monitoring and the drug administration. Then there'll be a scribe who has to document the date, time, and everything as they go and keep track of everything, which is what he is reading from now. And they write down everything that has happened, everything that they've done, and then he signs off at the end of the process.
And timing of the resuscitative efforts that were performed on Mr. O'Keefe's behalf.
Thank you. Your Honor, with the court's permission, may the witness hold on to that during the court's testimony?
Yes.
And Your Honor, what I would seek to introduce in a minute as the next exhibit would be a redacted copy of those same records.
Okay. Is there any objection?
Your Honor, if we could just review those.
Now, don't forget, John presented unresponsive.
Okay.
Might have queued it up at the wrong time. Let's skip ahead from that. Come on.
Okay, thank you. And Mr. Lally, I'll let you hold on to what's been marked SS for identification.
Now, Dr. Rice, with regard to Mr. O'Keefe, about what time did he come into your facility at Good Samaritan?
Would you like me to look at the chart here? Let's see.
Sure. If you can't remember things and you need to reference the chart, you can do that, Doctor.
Okay, thanks.
He's not going to
So
be
it
able
looks
to
like,
remember.
based on the code sheet, first line starting at 0647. So I'll say 6:47 a.m.
How good was that for memory?
And as far as his presentation, Mr. O'Keefe's presentation, when he came into the emergency department, how would you describe his presentation upon his arrival there?
So he would have been, well, he was unresponsive and intubated, as in with a breathing tube into his airway via his mouth.
And as he came into the emergency department, what, if anything, was fixed in regard to CPR or other resuscitative efforts?
So he would have had CPR in progress.
All right. So let's have a look and see what CPR is. Okay. So CPR stands for cardiopulmonary resuscitation. So basically heart, lung resuscitation. So basic CPR is assessing whether or not, firstly, your patient has a pulse. And you generally do that via the carotid artery on the side of the neck for approximately 10 seconds. If there's a pulse, that's fantastic. If there's no pulse, then the 5 cycles of compressions begin at the rate of 100 to 120 compressions per minute, which is actually quite fast. If you set it to a metronome, it's faster than you think. And the faster, the better. The actual compression to breath ratio has increased over the years because it's been shown that the more cardiac compressions you do, it brings up the blood pressure and allows more blood flow to the brain prior to giving the 2 breaths, especially if it's just one person doing the CPR, because you have to stop the compressions to give the 2 breaths. And that break that you take, the blood pressure drops back down again and you don't get as much perfusion to the tissues. So obviously CPR is better with 2 people at the rate of 30 to 2, and that person hopefully can sync their breaths with you as you release your compression, as you're lifting your hands. Now, advanced life support is the same thing, but just with more bits, so to speak. So he's come in intubated, which means he has a tube down his mouth. They generally go down through the mouth. Unless they can't get through the mouth, they go through the nose, but more commonly through the mouth down into the lungs. And they blow up a little balloon basically around the end of the tube, which holds it in place. And they blow a little bit of air through the tube and listen to make sure that there's no bubbles or they can't hear any gurgling, because that means they've gone into the wrong tube. They've gone into the stomach. So they blow in generally a little bit of air to make sure that they don't hear that, and that way they know that the airway is in the lungs. And they would have also assessed to make sure that his airway was clear prior to doing that. So just observing what's inside the mouth and clearing anything out that might obstruct the airway or might get pushed down by that tube being inserted. Generally, John was unconscious, so he would not have known that he was being intubated. But if it's something that happens with every general anaesthetic, and they generally give a muscle relaxant as well to assist that process. So again, it's basically maintaining your heart and your heart rate, your heartbeat to keep the circulation going, the airways so that you're getting oxygen to the blood that you are pumping around whilst you're doing compressions or on life support. And the other option is defibrillation. Now, that generally is used for two reasons. You could come in, cardiac arrest comes in a number of different forms. So John was classified as cardiac arrest because he was what's called asystole, which is basically the flat line. Okay, so no electrical or mechanical impulses. So every cell in your heart has the potential, the electrical potential to generate a heartbeat. And I'll go into that a little bit more in the next slide. But there are irregular heart rhythms that are not conducive to pumping effectively the blood around the body and circulating it, which is called ventricular tachycardia or ventricular fibrillation. You'll hear it commonly called a VF arrest, ventricular fibrillation, which means that the bottom two chambers of the heart are just fluttering on their own, basically, so they don't get a chance to work in sync with the top half and effectively push enough blood out through the lungs and then back through the body again. So defibrillation is basically the electric shock that they use to try and reset those cells and get the heart back into an effective rhythm that will maintain and assist in that circulatory and oxygenation. So that's what we call perfusion. So you want to keep the vital organs perfused with enough oxygen to keep them alive. So your brain, your heart, pretty much, because your body will not survive without it. Let's continue.
And also, someone would have been ventilating his lungs via the endotracheal tube.
So they would have had the bag that they squeeze.
Now, there's mention within that record as far as a cardiac arrest. Is that correct?
I don't know. I'm sorry. I don't understand what you're asking me.
Sure. Well, let me just ask you, familiar with the term cardiac arrest?
Yes.
Can you describe to the jury, based on your training and experience, what your understanding of that term is?
Sure. So, as in he arrived with in cardiac arrest, which by definition means that his heart was not autonomously or independently pumping blood, or in his case, without electrical activity as well of the heart.
And are you familiar with another term called perfusion?
Yes.
And can you explain what perfusion is and how that relates to the condition of cardiac arrest?
Sure. So, for example, you and I right now, because our heart is autonomously, pumping blood, the heart is the pump and responsible for pushing blood throughout your body, therefore perfusing your body. In a scenario like this, where a patient is in cardiac arrest or asystole, or as in not having any electrical activity in his heart or mechanical activity of his heart, the perfusion that is happening is by CPR, as in the chest being pushed upon, indirectly is, you call it maybe indirectly pumping or moving blood flow. So there is perfusion, but in a significantly limited compared to someone not in cardiac arrest.
And as far as that the perfusion process is concerned, what, if any, relation does that have to the organs within the body?
Well, so, if your perfusion is limited, then your organs are not getting the normal amount of blood flow and therefore oxygen and all the other nutrients that your blood's providing. So your organs will begin the process of failure.
You use the term in there as far as asystole. Could you explain to the jury what you understand that term to mean?
Sure. So asystole would be when you put the electrical leads on a patient's heart. The complete absence of intrinsic electrical activity from the heart.
All right, let's go back to our diagram. All right, so advanced cardiac life support. Your first one up is your circulation, so your heart. So the top two darker coloured areas on that diagram are the atrium, or the atria, sorry. So you've got the left and right atria. And then the bottom two are the ventricles. Then you have the lungs, obviously, the defibrillation, which is the shock where, you see on TV where they say clear. And that is basically recorded in joules. And you can do a number of shocks up to a certain level of joules when you're defibrillating a patient. But John's coming in flatline. So they're actually trying to restart the heart instead of triggering it back into a regular rhythm. Now, he also mentions that they use epinephrine. Now, epinephrine is basically a drug that improves cardiac output. So cardiac output and perfusion sort of work hand in hand. So you need to remember that when John came in, not only was his heart not beating, but he'd lost 2/3 of the volume of his blood as well. So he hasn't got enough red blood cells to actually hold on to enough of the oxygen when it does go through to be able to supply enough oxygen-rich blood to his vital organs, basically. So what I've put on here is I've divided the heart in half. You can see the little line that I've put through the top and the bottom of the heart. And I've recorded a basic ECG rhythm. And the red lines that separate each one basically show one heartbeat. So each one of those spikes, well, there's actually generally 3 parts to it. That occurs with every heartbeat. So if you think of the heart, the way that it functions, it's like a Mexican wave. So every cell is capable of producing that electrical impulse, as I said, and it can trigger a heartbeat. So every time it's triggered, the muscle contracts and relaxes. So we call that polarizing and repolarizing. So it's sort of a Mexican wave. It goes in and then back out again. It doesn't just go in and stop at the bottom point. It goes all the way back up again. So the first little blip in your ECG heartbeat is the 2 atria contracting together. Now, they should be working as one. They should be contracting at the same time. If they're not, it's an irregular rhythm, and that's generally called atrial fibrillation or atrial flutter. And again, they're just working on their own, not in sync with the ventricles. And a lot of people actually live with atrial fibrillation, but they need to be on blood thinners generally, because the heart, the atria obviously isn't moving all of the blood within the atria and emptying out completely into the ventricles. There can be a little bit of pooling within the atria and also backlog into the lungs. So you often find that with atrial fibrillation, you get short of breath very quickly. You can get fluid retention, fluid on your lungs, and your heartbeat will have lots and lots and lots of little spikes and then one big one where the ventricles contract. So they're not working in sync together. The heart has the two phases where the top half of the heart should contract together, squeezing the blood into the bottom half and filling the ventricles. And then the ventricles then should both contract together, squeezing the blood either through the lungs or out into the body. That's what the big spike is in your heartbeat in the ECG. And then the next little spike is what's called repolarization, where the ventricles then relax and the electrical activity is recorded as a T wave, basically. And then that allows the ventricles to refill again. And that automatically happens. So it's like a Mexican wave. And to have effective cardiac output and effective circulation, you need the top half and the bottom half to be working together in conjunction. So when you listen to someone's heart, you hear that boom, 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 or they call it lub dub. So that first boom is the two atria contracting. The second part, boom, boom, is the ventricles contracting together. And that is how the heart works the most effectively. That's how it's designed to work, basically. So if we go to the next one. So if the heart's working properly, it pumps that blood through to the lungs, and that then goes through all the little bronchioles and the alveoli, and it puts a fresh supply of oxygen into the bloodstream, provided that you've got enough red blood cells to carry that oxygen. So not only would have John had to have had multiple blood transfusions in that time frame, which I doubt they would have had the ability to do. His temperature was so low, it was like 9 degrees lower than the normal body temperature should be, and his heart wasn't working. So the odds were just stacked up against him from the start, basically. And they believe that he lost, from that head wound on the back of his head, they estimated 2/3 of his blood volume was lost from that. So you need to make sure that the lungs are clear of any obstructions, so any vomit. That's why when Dr. Rice did his examination on John, he said bilateral breath sounds, which means that both lungs were clear. There was no vomit at all and no foreign matter in the lungs or obstructing the lungs. So you could get adequate air through, which is why, as part of my theory, I believed that John was in a semi-upright position when he started to vomit. Otherwise, he would have choked on his own vomit if he was laying flat on his back on the lawn as he was found. What's the next one? Oh, so this is the defibrillation. So that's your next option. And that's basically to shock your heart back into a more effective rhythm or to restart it if possible. It depends on how long the heart has not been active for. So as I said before, the cardiac output depends on your blood volume, and the idea of epinephrine, it's basically a vasoconstrictor. So it constricts the blood flow from your arms and your legs, so from your peripheries, and it directs it back to the central vital organs to make sure that they get perfused with the oxygen because they're the most important. And it also increases the contractility of the heart. So if the heart's not pumping as effectively as it could be, especially if it's just restarted or it's been in an irregular and ineffective rhythm, the epinephrine will support the heart to make it contract better and therefore push more blood volume out and through the lungs, and then therefore keep that circulation and essential oxygen flowing, which is conducive to life. So the asystole is what John came in with. So that's basically the flat line. So there is no electrical activity at all, which means there's none of the cells are firing any electrical current. They're not conducting any electricity throughout, so they can't trigger the next Mexican wave and back again. And there's no mechanical activity as well. So if there's no mechanical activity, it often means that the actual muscle has been without oxygen for too long and is actually dead. So the muscle dies and then can't work, which is what I suspect. So obviously your brain needs a constant supply of oxygen, and if it can't get it, it slowly dies as well. And that's what he was saying. When you have a poor neurological output, it means that even if they can get your heart started again and pumping, if your brain has been without oxygen for a certain amount of time, the longer the amount of time, the more brain tissue dies, and the less you will be able to have a normal, like a lot of the things that we do are not necessarily something that we're conscious of doing. So, breathing, reflexes, that type of thing. They are things that automatically happen that we don't take any notice of. So the more brain tissue that dies, the less of those automatic reflexes and responses, the more of those die. So you will end up pretty much, in a vegetative state. If they did get his heart started again, it's almost like the lights are on but nobody's home. There's no brain activity. And I have seen it happen before, and it's not very nice. All right, so this is the Glasgow Coma Scale. I'll put Justin back on again. When he gets to that, we'll come back to this.
Would be asystole. So as in not having any observable or detectable electrical activity would be asystole.
Now, as far as these conditions, as far as cardiac arrest and asystole, what, if any, concerns does that raise from a diagnostic perspective in relation to Mr. O'Keefe?
I guess your question with respect to it from a diagnostic perspective, I don't know exactly what you're asking me there.
It was a terrible question from Lali, because it's not a diagnostic condition. It is a treat. It's an emergency condition to treat. It's asystole is no heartbeat. So if you've got asystole is your diagnosis. That is the diagnosis. So it was a poorly worded question.
With regard to those conditions that are observed and noted within the medical chart for Mr. O'Keefe that you have before you, how would that relate to his condition or sort of how he's presenting and what if anything you're doing treatment-wise?
Well, so even with good CPR, the perfusion of the brain, for example, and this is what I think about frequently during resuscitative efforts like this, as in, I couldn't tell you an exact time, but there's a certain, without perfusion of the brain for a certain amount of time, you're limited with respect to.
Whilst I remember, one of the main things that they do during the resuscitation of someone that's come in unresponsive, to establish their level of brain damage or brain injury, is often they will check the pupils with light. Now, the pupils, if they're not reacting to light at all and they're fixed and dilated, generally that means that there's too much brain damage that's not had enough oxygen behind it to support its life, basically. So yeah, pupils are generally non-reactive to light and fixed and dilated.
The concern is that the patient, even if you resuscitate their body, that there's potentially going to be brain death or anoxia or lack of oxygen to the brain, and a poor outcome with respect to neurological outcome.
Now, as far as the resuscitative efforts are concerned, is there any sort of standard sort of resuscitative protocols that would be undergone with someone who presents as Mr. O'Keefe did?
Yes.
And can you explain what those are?
So, in broad terms, there's AC.
The algorithm, the advanced cardiac life support algorithm, which is what we went through at the start.
ALS, which is advanced cardiac life support. That's an algorithm that through medical training, I've learned and is frequently the algorithm can be adjusted. There's also a TLS for trauma patients. So there's an algorithm there with respect to resuscitation or guidelines, I guess, with respect to resuscitation.
When he says trauma patients, he means someone that's possibly come in with a gunshot wound and is actively bleeding, that type of thing. So you wouldn't just start your CPR without stopping the bleeding first. That's pretty much what he's saying. So there's the two different protocols. You need to address the active bleeding before, as well as maintain airways and circulation. What was I going to say? And it's gone.
And within those sort of guidelines or protocols, are you familiar with a medication called epinephrine?
Yes.
And how would epinephrine play into sort of the treatment or the diagnosis of Mr. O'Keefe?
So, in the time that I've been practicing, epinephrine is probably the only medication or drug that has persistently been in the ACLS pathway. It's adrenaline. So the idea is loosely that you're attempting to affect upon the heart itself more squeeze, as in more pressure, and also to increase the potential, or if there is electrical activity, to increase the amplitude of that electrical function at the cellular level.
Now, in addition to the cardiac arrest and the asystole, as far as Mr. O'Keefe was concerned, what, if any, presentation did he have related to hypothermia?
So I know his initial temperature was low. I'd have to.
It was 80.
I was going to say I'd have to look, but I can see here that the nursing,
which is
wrote in their notes that his
Celsius.
I see T equals 80.1 R. So I interpret that to be his temperature was 80.1 degrees by rectal temperature.
Normal is 98.6 Fahrenheit,
Your understanding as far as
37
hypothermia,
degrees Celsius.
What is it, and how does that present itself?
So, as it pertains to this case, there's a few ways to get hypothermic. If I at 12:20 were to have a cardiac arrest right now and stop perfusing, my current temperature my current temperature, I'm guessing, is 98.6, right? A normal temperature. Without perfusion, the body will lose, or excuse me, the core temperature will decrease over time. The specifics of that I couldn't, or beyond my knowledge.
But if you're in the snow, your core temperature will decrease, obviously, a lot faster.
Training, but does that answer your question?
Yes. And so as far as hypothermia is concerned, is there a certain sort of baseline, or what is sort of the typical temperature under which someone would be declared sort of hypothermic or treated as such?
I don't know if I could give you a definition of medically what a quote diagnosis of hypothermia. I couldn't tell you a number. I can tell you that 80 qualifies as hypothermia, but I couldn't tell you a number under which that definition applies.
But the temperature that Mr. O'Keefe presented with certainly fits within those parameters. Is that correct?
Yes, 80 degrees is very cold.
And as far as resuscitative efforts as they pertain to the core body temperature or the low core body temperature of Mr. O'Keefe, what, if anything, was done with relation to treatment of that?
Sure. So as the nursing note mentions, there's a bear hugger was applied. So that's a blanket that has warmed air being pumped through it. So that's a way of externally warming someone. He also, having reviewed the chart earlier, I don't see it right in front of you. Actually, I take that back. He had warm IV fluids running. So IV fluids not at room temperature, as in a warmer or an oven of sorts, would have been given to him via intravenous or.
Now, warm IV fluids is great, but just remember already his blood volume is low, so you are essentially also diluting that further. So you really need to replace it with red blood cells, blood products, in order to effectively carry the oxygen around. Yes, the warm IV fluids will warm his core temperature and help with the volume, but it doesn't supply the hemoglobin component where oxygen attaches.
Central venous access.
And as far as the body temperature is concerned, what if any relationship does the body temperature have and the warming process have as to a declaration of deceased in relation to Mr. O'Keefe?
Well, so there's a goal in resuscitative medicine to attempt to rewarm a body. Loosely, the idea being that the heart, among other organs, will function better or function at all in a warmer environment. That's one goal of resuscitation. With him, as I recall, despite resuscitative efforts for approximately half an hour, there was not a significant warming of his core temperature.
And so, sir, with reference to Mr. O'Keefe, at some point, was he pronounced deceased by yourself?
Yes.
And do you see any indication within the chart as to what time that was?
7:50.
Sure, I'll just need this moment here. According to my note, it looks like the time of death was death declaration was 7:50 in the morning.
Is that 50 or
50.
Now, as far as the observations that you made as far as a systole and the cardiac arrest, did that persist throughout the course of your treatment of Mr. O'Keefe?
Yes.
So they weren't able to get his heart started again. And they worked on him from 6:47 to 7:50 in the ER, as well as the EMS doing CPR as they transported him to the hospital.
Direct your attention to what's the fourth page in, bottom of it says 2 of 4, and I direct your attention to the top of that page. Do you see that, sir?
Yes.
And as far as this is sort of a listing of observations or, well, let me ask you, can you describe what is listed at the top of that page there?
Sure. So this would have been the physical exam documentation of my note. So, with respect to the head, it says, excuse me, the first word is other, which I believe is a function of the computer system. As in, I typed in there right superior orbital ridge region, approximately 7 millimeter laceration, and then with surrounding soft tissue swelling / contusion.
Sir, if I could just stop you there. As far as what you're talking about with the right superior orbital ridge region, could you
Up
explain
here
to the jury or demonstrate to the jury?
Sure. So the orbital ridge is the bone above your eye that you can, like where your eyebrow is or should, would normally be.
And as far as the other sort of things that you noted over the course of your physical exam or review of Mr. O'Keefe, what, if anything else of note, did you observe?
Well, according to my note, the only other kind of observations other than would be that he had breath sounds present bilaterally. I observed that he was pulseless. His abdominal exam was atraumatic on my chart. And then extremity exam or musculoskeletal exam, I wrote that he had superficial abrasions on the right forearm.
And from a medical perspective, when you use that term abrasion, so can you explain to the jury what you understand the term
I
abrasion
think
to
he,
be?
Yeah, I use it as a medical synonym for scratches, if you will.
yeah, they're not scratches.
And under neuro or neurological, there's a listing as far as a GC3, is that correct?
No,
Yes.
And can you explain what that is and what that means?
So GC is what I charted. What I intended to write there was GCS, which is a Glasgow Coma Scale, which is a...
All right, let's have a look at the Glasgow Coma Scale. All right, so basically it's 3 components and it's designed to work out the level of damage to your brain pretty much and your responsiveness. So whether your eyes are open spontaneously, which is what you want to have the highest score, which is 15. So eye opening spontaneously gives you a score of 4. If you open your eyes just to speech, it's 3. If you open your eyes just to pain, it's a 2. Or if you don't open your eyes at all, it's a 1. Verbal responses are obviously if you're orientated to time, place, and person, or confused, or no response, it goes down again. And your motor responses, which are the reflexes I was telling you about. So, the doctor hits you on just under the patella and your leg flips up, that is a response, a reflex that happens automatically without your brain having to think about it. And they're the things that they use to assess how much damage has been done. And John arrived with a score of 3, which is the lowest score you can get, which is totally unresponsive. So he was not responding to his eye opening. He wouldn't open his eyes or couldn't open his eyes at all. Not even to pain. They generally do a sternal rub to see if you can open your eyes to pain for that. He wasn't responding verbally and he did not have any motor responses that they could find. So, yeah. They were pushing the proverbial uphill, I think. Unfortunately.
A scoring system to identify someone's level of consciousness or unresponsiveness.
And as far as the three, what is, like, where does the scale start? Where does it go to, and where does the three fit in?
So there's three components: verbal function, motor function, and eye or ocular function. And someone who's completely unresponsive, as in no motor, no verbal, and no eye movement or function, completely unresponsive. The lowest you can get on the scale is 3.
Thank you, sir. Madam, may I approach just to retrieve?
Yes.
Now, later on over the course of that same morning, did you have occasion to become involved in the treatment of another patient by the name of Karen Reed?
Yes.
And may I approach the witness again, Your Honor?
Yes.
So I'm showing you another document, just ask you to look at that. To the extent you can recognize it and look up whenever you finish.
Now, he was probably in charge or the most qualified physician for that day, which is why he would have treated both of them. He probably didn't even see Karen. He signed off on hers after been giving a report from his attendings, no doubt.
In general, sir, do you recognize what that is?
Yes.
Or what do you recognize it?
The first part I recognized would have been the medical record or medical note with respect to Miss Reed, who was also a patient that morning.
This is when she was involuntarily
Your Honor,
sectioned.
the Commonwealth seeks to introduce in a minute the next exhibit or redact a copy of those records.
Regarding no objection, subjects to the redactions.
Okay, thank you.
This is exhibit 106.
Thank you.
Now, sir, if you know, about what time was it that Miss Reed came into the emergency department at Good Samaritan that morning?
I mean, I can tell you from this chart, it looks like that at least the first posted vital signs were from 7:51, 5:1 in the morning.
And in reference to Miss Reed, what is it that she came into Good Samaritan in regard to? Why was she there?
I'd have to review Daisy's note. So
That would have been the triage nurse.
Well, let me ask you this, sir. Was it in reference to Section 12? Do you recall?
yes.
And with regard to Section 12, patients that come in regard to that, what kind of involvement do you have, or who, if anyone, do you work with in regard to those types of patients?
Sure. So Section 12, I would define as involuntary detention of a person, usually for a mental health concern.
They have to be
whether
normally a
that's
danger to themselves
self-harm
or
or
someone
harm
else.
to others, or if someone who's afflicted with schizophrenia or psychosis, members of the public can bring someone to the police, or members of the public can bring someone to the hospital on a Section 12, which again involuntarily detains them for evaluation.
And that would be
And
from a
in addition to
psych.
yourself, is there other staff? You mentioned that there were
Psychiatrist, not so much him.
physician's assistants or nurses that were working.
Yeah.
What
If there was any medical conditions that were associated or that were causing the psych condition or the risk associated with harming potentially harming herself or others, then he would address those. But the actual Section 12 and the assessment would have been done by the treating psychiatrist and not so much by Dr. Rice.
How much involvement would you typically have with someone who
It's like if you came
comes in on
in labour, he is not an obstetrician, so you could be admitted under his name, and any medical complications that could be occurring at the same time, he could treat, but you are generally are then referred to obstetrics and under their care. If that makes sense.
that kind of prognosis or diagnosis?
I would say, to answer your question, my involvement is variable and dependent a lot of times on what that nurse practitioner or physician assistant feels like they need or want my involvement to be.
And what kind of involvement would you have as far as when someone comes in with that kind of issue? What is sort of the typical protocol or policies that a Good Samaritan would undergo with reference to that patient? What are you doing with reference to the patient when they arrive?
I'm sorry, I think I don't really understand what the question is.
He wouldn't be doing a lot. It would be triaged.
So, with regard to a patient coming in on a Section 12, what happens with that person once they present in the ER?
So whether they're evaluated by me or a nurse practitioner or physician assistant, if that person feels like, based on their evaluation, that they need a mental health consult or evaluation, then they would have that initiated, as well as what we do for a lot of patients or all patients, vital signs, and sometimes blood work as well.
And when it comes to that sort of blood work or assay, as far as what's being done with someone who comes in with that kind of report, what is sort of being tested and what is being looked at as far as the blood work is concerned?
Well, there's a few reasons to get blood work, but in general, part of the evaluation is, with respect to the medical presentation, to make sure there's no medical emergencies present, in addition to whatever.
You could have an abnormality or an imbalance of something in your blood, so you could a vitamin deficiency or something that could cause potentially psychosis or an altered conscious state of some kind, and so they do the blood work, and if it comes back that is the actual cause of the mental health issue, then that's the medical underlying cause that they would treat. So he would treat that. They would probably still get a psych evaluation as well, but they would treat the medical underlying cause and reevaluate the patient's condition once that underlying medical cause has been addressed, which is why they would do a full blood workup. But they also did blood alcohol concentration on Karen, and it came back at, I think, 0.07 to 0.08, which is just under the legal limit, and that was done, I think, at about the 9:30 a.m. mark. So they worked out somehow that her blood alcohol concentration would have been, I think, between 1.3 and 2.9 at the time. At the time of the incident or the time that she was driving, but that is a massive, it's a huge gap. So 1.3, you could be tipsy, happy and giggly and still quite capable of having a decent conversation, not slurring your words, and just be tipsy drunk type of thing. Whereas 2.9, this is like that's stomach pump stuff. That's blood alcohol poisoning almost. And especially in someone that's such a small frame of Karen, that she could have potentially had alcohol poisoning at 2.9. So the huge range that they came up with is not, in my opinion, it's not specific enough to actually estimate that what her blood alcohol concentration was at the
The
time.
mental health concern may be. There's also blood work drawn with respect to disposition, as far as some people, for example, it would be inappropriate to have a mental health evaluation if, for example, I were intoxicated on alcohol and my alcohol level were elevated, because I think the idea is that you're not getting, a true representation maybe of what's going on.
Everyone
Am I correct in that
metabolizes
someone
it
presents
at
and then
different
there's
rates.
like sort of you medically clear that person as far as any sort of injuries or anything like that first?
I wouldn't say first necessarily. I think a lot of times these processes happen in parallel.
So in parallel, you have the medical clearance and then sort of psychological clearance as well.
Sometimes, yes.
And then sort of involved in both of those, there would be blood drawn and reference to a section 12 as far as a typical one would be looking for sort of alcohol and drugs of abuse, things of that nature.
I mean, I'm hesitant to answer yes because of the word typical, because I wouldn't say there's really a typical presentation with respect to
mental health
presentations in the ER.
And from your
hello and
record
welcome,
or your
Walter Jura.
remarks
Hello.
as far as the blood work.
Thank you very
done
much
with
for
regard to
joining
Ms.
us.
Reed on this day.
You're asking me if blood work was drawn?
Yes.
We are just going through the Dr. Rice's testimony on what he did as far as the resuscitation of John O'Keefe when he presented at the Good Samaritan Hospital. And I've sort of I did a presentation on a bit more of a deep dive and explanation on what they did and why they did it, and why the outcome was what it was.
I believe so. I have to double check. So yes, it looks like there was blood work drawn.
Now they're talking about Karen's
And among the
presentation
things that were tested
under the
within
Section 12.
the facility within Good Samaritan was the alcohol screen. Is that correct?
Yes.
And what is the result of that alcohol screen that's contained within those records?
Do I answer or no?
Alternate juror, were you on one of the jurors on the Take Care of Maya trial by chance? Just out of curiosity?
Yes.
So it looks like 93.93. I'd have to maybe look deeper in the chart to tell you the units of that measurement. I don't want to guess. So, but to answer your question, 93.
Can I approach this briefly on?
Yes.
Have you been a member on a jury recently? Or is that just a clever screen name like the defense rests? I'm sure I've seen you in the chat on Recovery Addicts channel.
I'm directing your attention to a Oopsie tab portion of that.
Sure.
Do you see the units that 93 pertains to contained in that record, sir?
So yes, it looks like it's milligrams per deciliter.
Thank you, sir. May I approach this to retrieve, Your Honor?
Yes.
Thank you, sir. I have no further questions of this witness, Your Honor.
All right, Ms. Little?
Oh, wow. Congratulations. It's exciting, isn't it?
Good afternoon.
Hi.
I've only
You
just
testified that you
about 2 months ago.
treated Ms. Reed when she arrived at the hospital on January 29th, correct?
I don't know if I testified that I treated her, but I was involved in her care. Yes.
Pop your, is it at alternate juror on YouTube? Pop your the link details in chat so that people can come and join and sub.
You actually wrote the reports regarding her care, correct?
That is not correct.
Would it refresh your recollection to take a look at the report?
So
The report, I believe we're talking.
he would have signed the report because he is the head physician at the time, but he necessarily didn't write the report, which is what I was explaining before. He probably didn't have much to do with her admission at all because it's triaged, and he would have been taking care of probably John or someone else who's at a higher level, unless there was no one else underneath him that could actually look after Karen. But they would report back to him and he would have to sign off on it, which is why he signed the report.
About the note, the emergency room note was written by a nurse practitioner.
Would it refresh your recollection to take a look at some additional reports from January 29th?
Sounds like you want to show me some reports, so sure.
He can't honestly remember every patient he's seen and every report he's written. May I approach, Your Honour?
Yep. Okay.
Poor guy, he's probably got 1,000 places he'd rather be than sitting there.
Do you recall treating Ms. Reed on January 29th?
I do not.
Do you recall writing a report?
And go over, sub the alternate juror.
No, it depends what you define report as.
I'll be going over there as soon as the stream's finished.
To best answer your, well, do I recall writing this note? No. Was that what your question was?
So is it your testimony that do you recall treating Ms. Reed at all?
No, I don't.
Do you recall actually ordering her blood in this case?
No.
No.
Do you recall sending
That
her
would
out
have
to the
been
labs at all?
a passing, okay, give her a full blood examination, do blood alcohol content, do this, sign, go. He would have been walking past, done. He would have no recollection of that whatsoever.
No.
As you sit here today, you don't know who collected the blood?
That's correct.
No, that would be the phlebotomist.
Oh, who packaged the blood?
That would also be a fair assessment, yes?
Yep.
And you don't know who submitted that to the lab?
Correct.
And it wasn't you, correct?
No.
I can confidently say that I did not
Yeah,
collect blood work. I did not do that.
Okay.
He would have written the slip and the phlebotomist would have done the blood draw. As per hospital protocols.
You testified that you treated Mr. O'Keefe upon arrival on January 29th, correct?
Yes.
Did a firefighter ever approach you on the morning of January 29th and tell you that he had information suggesting that the victim had been struck by a vehicle?
Objection.
Do you remember that?
I do not.
So if a firefighter indicated that he informed you that he had information suggesting that Mr. O'Keefe had been in some sort of vehicular accident, that's something that you would have included in your report, correct?
Mm-hmm.
I don't know if that's a fair assumption.
But as you sit here today, you have no recollection whatsoever of anyone telling you that the victim had appeared to be in some sort of car accident, correct?
Well, I think, I don't have it in front of me, but I think my note that I prepared for Mr. O'Keefe states that per EMS
So he would have been given what's called a handover when they brought him in
Dr. Rice, you
to the
have no
emergency
record.
room. The EMS would have told him what they'd done, what drugs they'd administered, when they'd intubated him, what his vital signs were.
So I think that what I was trying to say, right, was that on my note, it says per EMS report. So one of the medics, as in one of the folks on the ambulance who brought Mr. O'Keefe in, again, I'm not right in front of my note, but as I recall, it said something to the effect of per EMS report, the patient may have been struck by a vehicle.
Can I show you a copy of that report?
Please.
So he's just referred back to, instead of rewriting everything, he's said refer to EMS report, who would have documented all of that. But that's not really something, it's something he keeps in the back of his mind for potential injuries and internal bleeding and what have you, but it's not really part of his assessment as far as advanced cardiac life support and the resuscitation that John needed at the time.
Yes. You could take a look at that.
All right. So,
I'll ask the question. Is your
course.
recollection fresh?
yes.
Is there anywhere on that report that says that the patient came in and there was a statement by EMS that the victim appeared to have been struck by a vehicle?
Just give me a moment to read through the.
Sure.
So no, there is not.
In fact, there's no mention of a vehicle whatsoever, correct?
Mic drop.
That's correct.
Awesome. That'd be fantastic. We could do a collab.
Dr. Rice, did you observe Mr. O'Keefe's injuries when he arrived at the hospital that morning?
I guess you'd have to define what observe injuries means.
Well, during the course of your treatment, did you inspect him for injuries?
So, yes,
You testified that you observed certain abrasions and scratches on his right arm, correct?
yes,
Aside from his injuries to his right arm, and I believe you described sort of a laceration above his eye, John O'Keefe did not have a single other injury on his body from the neck down, correct?
I don't know if that's fair to say.
Well, you didn't report a single injury to his shoulders, correct?
It's all in all caps, sorry.
You did not report a single injury to his chest, correct?
Correct.
You did not report a single injury to his torso, correct?
Correct.
You did not report a single injury to his back, correct?
Correct.
You also did not report a single injury to his ribs, correct?
Correct.
No injury to his hips, right?
Correct.
You observed no injury to his knees, correct?
I reported no injuries to his knees. Correct.
No injuries to his
Which you would
shins,
expect.
correct?
Correct.
No injuries to his ankles, right?
Correct.
You're welcome.
And no injuries to his feet.
Correct.
From the neck down, he did not have a single broken bone, right?
Well, now this
I don't
is
know if-
what he doesn't know, that because if they would have palpated his abdomen, which he said at the start, and there was nothing that he could feel, so there was no. Often, if you're bleeding internally, it doesn't sound as hollow when you tap on it. So he's assessed that. So there's no obvious internal bleeding. There's no obvious external bleeding. So he hasn't got any open fractures or any huge wounds. So he's not actively bleeding from his extremities or anywhere else. There was some blood loss from the laceration to the back of his skull, but as you can see, yesterday when I did my theory live stream, and we showed the pre-autopsy photos with the lacerations and his injuries. If he's been in asystole for, an hour at least, which is what he was in the ED for, then obviously you're not going to have as much blood loss because he's already lost 2/3 of his blood volume prior to that. So when they're doing CPR and they're doing chest compressions and they're doing the breathing, then they are starting the blood to circulate. So then he would then also start having some minor blood loss to that area as well. So that would explain that. But
That's a fair assessment or statement.
there was no obvious
You certainly
injuries
didn't
from the
locate
neck
in your
down,
report that he had any broken
which you would
bones from
expect
the
from a
neck down,
vehicular
correct?
pedestrian.
No, I
Accident.
did not. I'd happy to explain that, but to answer your question, no, I did not.
You did not report a single fracture from the neck down, correct?
I did not report a single fracture.
They
Correct.
would not have even bothered to do. Well, I'm saying that. I'm guessing they would have been focused on his heart and breathing without doing an X-ray in the middle of it. There's no point doing an X-ray to see if you've got a broken leg if your heart's not going to start again. So that's why he's saying I don't know if there was any fractures.
Injuries
They
that you
wouldn't have gone
testified
any
to
further.
today were that he had sort of a laceration above his
I don't
eyelid,
think.
correct?
The injuries that I testified to today, correct, yes.
And the scratches on his right arm.
On the right forearm, yes.
Yeah, they're more than scratches.
No further questions.
But if he hasn't got the photos in front of him, then
Dr. Rice, with reference to fractures or broken bones, can you explain sort of why that may not have been noted or why that wasn't included within the chart?
Sure, yeah, I'd like to. So with a patient like Mr. O'Keefe who came in, the focus of myself and the team of physician assistant, nurse practitioner, and nurses, whoever was helping in a case like this, the focus is in core resuscitative medicine, of securing an airway, making sure he has a breathing tube in, making sure that the CPR is being applied the right pressure to the right place, making sure that the core resuscitative elements of medicine are
which is what
happening
we went
unless,
through with the advanced cardiac life support at the start of the stream.
as in the mind can only focus on so much. So I think in cases like this, because the attention is on resuscitation of someone's heartbeat, their life, there's less focus on injuries or observations that
This is what
don't.
He's trying to explain triage, basically. So they basically grade everything in a matter of importance. That's pretty much what it comes down to. And obviously it is the most important thing to keep his heart beating and the blood being oxygenated and circulating. So it's the X-ray to see if he's got a fractured toe, perhaps, is way, 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 way down on the list.
Coincide with the resuscitation effort or not pertinent to that resuscitative effort, if that answers your question.
So in that vein, it's not like you're doing X-rays or a full skeletal survey or something like that.
No, we're not doing a full skeletal survey. No.
And besides, that costs money as well. It's a waste of, well, not a waste, but it's a resource that's unnecessarily needed.
Correct, unless there was an extremity injury that would be pertinent to his resuscitation if he had had a traumatic amputation, as in removal of a leg, for example, that would be pertinent to a resuscitation, but an otherwise intact extremity, that is not necessarily within the realm of resuscitation.
You would know if there was a damage done to an extremity, because what happens when you break a bone, you have bruising and swelling straight away. So there was nothing notable when they did the assessment at the start. So they would not have followed up on that with an X-ray, basically.
Resuscitation.
May I approach the witness?
Yes.
I'm going to direct your attention on the document. Indicates discharge and clinical impression. If you could just read from that, look up when you finish. Read to yourself.
I'm sorry, what would you like me to read out loud?
So as far as the chart is concerned, as far as your clinical impression of Mr. O'Keefe, can you read sort of what you...
Sure, right. So I wrote clinical impression, cardiac arrest, head trauma, exposure to environmental cold.
May I approach this to retrieve her?
Yes.
No further questions.
Anything further, Ms. Little?
No further questions.
All right, thank you, Doctor. You are all set.
Thanks.
So that was Dr. Justin Rice.
Rather than where it's 10 minutes or one, jurors, can we do?
All right. Let's take that off there. Oh, bing, bong, bang. I'm back again. All right. So, well, I hope that explained a little bit more and made a little bit more sense to you as to what they actually do in emergency resuscitation, what techniques they use, what CPR and advanced cardiac life support, how they assess and treat patients that come in. But basically, he could not have come in a worse condition. His conscious level was the lowest it could be. His heart had no electrical or mechanical activity, and he was unresponsive. So neurologically, brain damage was a high potential that there was serious brain damage. So even if they did get his heart started back again, in the off chance that they did manage to do that, his chances of having a normal life at all would be extremely, extremely slim, extremely slim. So that's the medical side of Justin Rice's testimony, and he's probably a fantastic ER doctor, and unfortunately he's been called up to the stand and put on the spot. And yeah, I know when we were watching the trial, when it was on live, he copped a lot of slack on his testimony and his difficulty in explaining stuff. But you need to just take that in your stride, because he didn't sign up to be a public speaker, and he's now testifying in front of an international audience, millions and millions of people, and he needs to be cut some slack, I think. So I hope you've enjoyed the stream tonight. If you want to go back to yesterday's live stream, as I said, I did a big evaluation on all the testimonies, evidence, and all sorts of, with the phone records, the dog, the timeline, everything. And I put together what I thought could have been could potentially have been what went down at 34 Fairview that evening, logically. So if you want to go back and watch that, that would be great. If you could smash that like button for me, That would also be fantastic. We're slowly building up some numbers, which is great. We're growing every day. So I'm so thankful for everyone's support. And also head on over to Alternate Juror 1. So at Alternate Juror 1 on YouTube. Go and check them out. Like and subscribe their channel. And yeah, do the same here if you can. Takes a second and it's free. So thanks again. Oh, and also because I've only been this channel's only a wee baby. It's only been up for about 2 months. So it's not monetized at all. So if you would like to support the channel monetarily, there is, if you see in the top corner just there, is the QR code that you can scan, and that will take you to an app where you can buy me a coffee. Because in Melbourne, it's for me to have live streams at a time that is reasonable in the US. It's actually quite late at night for me. So a coffee would be great. All right. So with that, I shall sign off until next time. Thanks again, whether you've come in on live or you're visiting from the replay crew, you're welcome at any time. And until next time, I shall bid you adieu. Where's my outro? Come on. There we go.
And police arrest, where the judges move and the defense rests. Watching courts and trials, criminals at best, where the gavel drops and the defense rests. If you love true crime and you want the best, won't you find the time and the defense rests?